Basic principle is all the pelvic muscles, levator ani, holds all the pelvic organ intact, and fourth, of course, sphincter. Now, what is the mechanism of continence? We should understand. First theory which came was hypermobility theory. I think, madam, you know, this all this due to my teacher, Professor A. Rajshekhar, is to make me go into fundamentals of every subject, basics of everything. What is hypermobility theory? Hypermobility theory, a patient coughs, pressure is equally transmitted to bladder and bladder proximal urethra. So what happens? It nullifies. But what Delancey, I think Delancey, what he thought, the patient mobility urethra was in abdomen, patient still had urinary incontinence. Then we proposed one theory based on ligamentous theory, based on it is endopelvic fascia, pubo-urethral ligament, pubo-cervical ligament, and pubo-vaginal ligament. Whenever a patient coughs, the ligaments is held, the urethra is held by the ligament. He proposed a theory of hammock theory. I think it's hammock theory. Then comes Holmstein theory. He is a little smart fellow. He combined both. He combined hypermobility theory as well as hammock theory and proposed with the help of levator ani muscle. It's called Holmstein or hammock's effect. That is, he focuses on pelvic floor muscle at all. Keeps the pelvic floor taut. Whenever patient always pelvic muscle, levator ani muscle, especially pubococcygeus muscle, part of this muscle interlaces between the urethra and the vagina. It holds the pelvic organ intact. So this strengthens or treatment depends on all the following. And finally, sphincter. Why should you find sphincter deficiencies? 5% of deficiency is in sphincter deficiency. You cannot treat all this. So these are basic concept of female incontinence in quantum mechanism in female urethra. Now, in little bit of initially it was history, very interesting history. Initially it was thought only proximal urethra. Then advent of urethral pressure profile came. What they did was, as you withdraw, the pressure was not in the bladder neck, it was mid urethra. It was diagnosed only after urethral pressure profile. It came to mid urethra. It was so that the structure, the functional one mechanism in the region of mid urethra. So that was the principle. And as she correctly said, genuine stress incontinence, UDA has got no role. Filling phase will not have contraction. Voiding phase will void normally. If you only have a mixed filling phase, will have hyper detrusor contraction. So detrusor contraction will be seen in overactive bladder. Stress, genuine stress incontinence, filling phase of systometry will have normal. That's a quantum mechanism of female urethra. Very important. Understand the surgical method of overactive bladder. Why you give pelvic floor exercise? Why you stress urinary incontinence? Why it came from Stami's procedure to mid-urethral sleep? You have to understand the history beyond the hyper pressure theory and mid-segment increase in pressure, Delancey, and all that combined theory. Then only understand. And the Kegel's exercise, actually, it's a small history which my chief told. It was initially invented not by Dr. Kegel. It was one dancer, Margaret Morris. I think you may not know that, but that was copied just like we copy in our own thing. We forget, we only think of Duckett, not about giant people who invented hypospeed, as you mentioned. Asopa, no one mentioned here. He's a great inventor, great simple man, but we only talk about Duckett. But Asopa was just a gentleman. We should appreciate him because we are Indians, we don't praise Indians. That's the problem. Thank you. Well done.
Thank you. Really good presentation, Dr. Bhargavi. So regarding the urodynamics in stress urinary incontinence, definitely urodynamics won't diagnose stress incontinence, but it rules out anti-incontinence. Okay, so it rules out anti-incontinence. As well as it will be very useful in elderly females, especially diabetics, and it rules out retrus are underacting. So in both the conditions, the anti-incontinence as well as retrus are underacting. If you are offering surgical treatment for the patient with stress bleed, it will aggravate the symptoms rather than improve the symptoms. So that way,
Thank you very much for the wonderful presentation. I just stay on for the small present and I request Professor JV to kindly come forward and honor the
Videos.
Production, can I just have a photograph? Yeah, you can, please go ahead.
உங்க இதுல ஜூம் இருக்குல்ல உங்க மொபைல்
Request Professor JV sir, the kindly honor Professor Rajaram sir.
வந்து இப்போ உங்க ஜூம் வந்து ஓபன் பண்ண
Thank you very much for the zeal and enthusiasm you have shown right from the beginning of the talk. Thank you very much. I request Professor JV sir, the kindly honor Dr. Vedavendan.
இன்வைட் போடுறேன் உங்களுக்கு அனுப்புறேன்.
Dr. Hemalata, who is also the technical coordinator of the program. Now coming to the topic which many of us are waiting for. This is the topic of Professor Rajamaheshwari ma'am, and who is going to chair this session will be a very interesting question. So may I have the honor of requesting may I request Professor Srikalama ma'am to kindly be on the chair, please.
லோட் பண்ணல வாங்கிக்கோங்க.
May I request Professor Muthalata ma'am to kindly be on the chair, please. Professor Venkateshwari ma'am, would you like to chair the session, ma'am? Because you will have a lot of doubts to ask Rajamaheshwari ma'am. Yeah, please.
Madam requires
Mic
no
on.
introduction at all, really. The
நீங்க
mother,
ஒரு
father of
நிமிஷம் செட்டில் பண்ணி
urogynecology,
கொடுத்துறேன்.
not only in India,
என்ன
all over,
பண்ணுறது அவங்க லேப்ல
and has been
கொடுத்தாங்களா?
a mentor to almost all of us. May we request Madam to close the light on this great field.
Thank you very much, Madam Shekala, Madam Ambedkar. Dear colleagues and friends, it is an honor and privilege to be here with you all. Let me just talk about the surgical management. There are so many surgeries, vaginal procedures, there are so many, now echo. Okay. Vaginal procedures, abdominal procedures, minimally invasive procedures, combined procedures. So you are at a loss, which operation for which patient. And you know that many of the tips given by Bhargavi and Dr. Rajaram. So you choose your operation for the best result. Okay. When to do the compensation, when to opt for during things or people vaginal sleep, you need to use your own discretion. So you need to select the right patient and the operation. So as Dr. Bhargavi pointed out, it is very important to know whether you are dealing with a case of complicated SUI or uncomplicated SUI. So uncomplicated SUI is the one that is likely to have the abnormal urethral function with low MUCP, leak point pressure, non-mobile urethra. So these are going to give you poor prognosis. So it is worth remembering that the hypermobility and intrinsic sphincter deficiency are different extremes, and there is often combination. Whichever is predominant, you need to address the surgery, which will tackle it. So, how do you diagnose intrinsic sphincter deficiency? How many postgraduates are there? Okay. So, are you all aware that how do you diagnose intrinsic sphincter deficiency? Have you seen cases of intrinsic sphincter deficiency? Yes or no? No? Never mind. Right. So, you can just diagnose these cases. They will have severe leakage with minimal exertion. They will have well-supported urethra. The urethra closure pressure will be less than 20 centimeters, leak point pressure less than 60 centimeters, and they will have an open fixed urethra which is refusing to close when you do a scoping. So, what are the options that you have currently? So, you have pump suspension, PV sling, bulking agents, and synthetic material slings. Let us start with Burst corpus suspension. So Burst corpus suspension is a very good operation. You take the paraurethral tissue at the bladder neck and the proximal urethra, and you attach it to the failure. So 5 years, it's 21%, and then need